we slowly deteriorate, our muscle tissue deteriorates. It is a real problem in Western society. It's called sarcopenia. Hello and welcome to another vlog on YouTube and podcast on Spotify by the Fit Minds podcast. Coach Mariah Jean here. Today I'm going to be talking about weight loss drugs, specifically GLP-1, glucagon-like peptide drugs for the purpose of weight loss. So for those of you who've landed on the podcast who are currently on the drug or considering going on it, I do suggest that you strap in for the podcast of your lifetime. And for those of you who know anybody who is on this drug, please send them this podcast. Sincerely, signed a nutritionist, registered and insured to practice in Australia, who is more qualified to speak on the topic of nutrition and weight loss than anybody you will probably come into contact with, specifically in comparison to your general practitioners prescribing such medications. Can you tell? I do not have a personal bias in relation to the prescription nor use of these medications, but I do definitely have a professional standpoint. And I will talk about all of the facts, the scientific facts that we have in front of us, rather than speak from an emotional standpoint. And I would like to say as well that there has been little to no impact on my business as a result of weight loss drugs being, I don't know, what would you call it, propelled into popularity of late. It doesn't change anything for me. My business is thriving. It's actually busier than ever. The reason I'm doing this podcast is because of the risk involved, the long-term risk, and also the, I suppose, lack of education, not just for the users, but also the prescribers of this medication. Okay, so let's talk about what is GLP-1. It's a hormone that helps control blood sugar and appetite by stimulating insulin release, inhibiting glucagon, slowing gastric emptying, and increasing feelings of fullness. These effects, which the body naturally produces, yes, we naturally produce them in response to eating, are mimicked by GLP-1 receptor agonists, medications used to treat type 2 diabetes and obesity. See how originally the use of this medication was for type 2 diabetes and is now being used as a secondary measure for obesity. By activating GLP-1 receptors in the brain and gastrointestinal tract, these agonists help lower blood sugar, reduce food intake, and promote weight loss. So you might be thinking, wow, this sounds super exciting. There's a drug for weight loss. Oh my God, there's a pill for everything. It's going to solve all my problems. I better jump on this weight loss drug immediately. I'm here to tell you that you probably shouldn't. And it's not because I want you to come and coach with me. I'm full. I'm full. I couldn't get any fuller than full, but I do have room, but meaning that there's no incentive for me. I'm happy. I'm content. I don't need more clients. Risks of GLP-1 agonists such as Ozempic, Wegovy, and Mounjaro include common, usually mild side effects like, mild, nausea, vomiting, just mild, diarrhea, and constipation, because that's something that you're going to be able to live with for the rest of your life. More serious but less common risks are pancreatitis, gallbladder problems like gallstones, and gastroparesis, delayed stomach emptying. Additionally, there is a warning regarding anaphylaxis and an increased risk of pulmonary aspiration during surgery due to delayed gastric emptying. I'd just like to say that these are some of the known side effects. There are some unknown side effects that aren't listed just yet because we don't have the long-term studies. We do not, no matter how much specialists or GPs try and talk about this idea that there's all these studies. There are only studies that exist, long-term studies on diabetic patients, not non-diabetic patients, which we know would work completely differently for a general pop individual. I will continue. GLP-1 receptor agonist, GLP-1RA therapy can lead to substantial muscle waste, with up to 25 to 40% of weight lost being lean body mass. This loss of muscle mass is concerning as it can lead to decreased strength, increased risk of falls, frailty, and potential worsening of chronic conditions like osteoarthritis. To mitigate muscle waste, patients are advised to focus on a high-protein diet and incorporate regular resistance training into their lifestyle to help preserve muscle. Do you think that is happening? If we could take studies or surveys, or maybe even pull some statistics from these I would call them guinea pigs at the moment, who are taking GLP-1s, how many of them are engaging in resistance training and eating enough protein to be able to preserve muscle mass and promote muscle growth even so, because a lot of people are already deficient in protein or even muscle mass for their size and structure. And you might think, well, I don't really care about muscle. What do I need muscle for? As you age, muscle tissue prevents you from having falls. It prevents you from falling down the stairs and breaking your hip, okay? It means that you're able to be strong enough to get out of your chair, to reach up into the pantry to get things out of the pantry. That may not be a problem for you now, but as you age, you don't just have this natural ability to be able to perform everyday tasks. You need to engage in some sort of resistance training of some sort or exercise in order to protect this muscle tissue long term and promote muscle growth. Because as we age, we end up with a protein resistance which occurs over time. And as that occurs, if we don't basically buffer that with an increase in protein in our diet, we slowly deteriorate. Our muscle tissue deteriorates. It is a real problem in Western society. It's called sarcopenia. And it is what is crippling the hospital system, especially from a perspective for the aged care industry and those who end up in hospital with physiotherapists who are seeing this on the front line. People who are having falls and harming themselves. And you see this as you age. You see it as people get older. Their muscle tissue degrades. You can visibly see it happening. So when you go on a weight loss drug, most of the weight that you lose is in fact, 25 to 40%. I won't say most of. There'll be some water in there as well. But a large chunk of it is going to be muscle mass. So the focus is not and should not be on just weight loss, but fat loss should be the focus. And unfortunately, these drugs do not promote just fat loss alone. Without the use of the drugs, can you? Absolutely, you can look at only losing body fat and being able to mitigate muscle waste. Absolutely, we do it every single day as nutritionists with correct dietary changes, resistance training, and not actually needing the drug at all. So the drug actually increases the chance of muscle wastage, even with protein and resistance training, right? Added in there, you're still going to have that risk of atrophy. So the risk of atrophy increases. Okay, so potential consequences of muscle deterioration can compromise physical function, mobility, and long-term health, potentially increasing risk of falls, frailty, and pain, especially in older adults. Common side effects of the drug: gastrointestinal issues, nausea, vomiting, diarrhea, constipation are most frequently reported side effects and the most common reason for discontinuing the medication. Oh no. Isn't it interesting to think too that if you were just to make some changes to your nutrition and exercise, and to be completely honest, it's not that drastic, you would not only experience the benefits of fat loss specifically and muscle promotion and muscle protection, but you would also not experience these gastrointestinal issues, right? Unless you were, consuming something that gave you diarrhea, if you were intolerant. Injection site reactions, temporary redness, itching, or pain at the injection site can occur. Less common serious risk, pancreatitis. There is a potential though debated, risk of acute pancreatitis. Now, I'm taking this from ChatGPT, but this is obviously from the most common answers that we're seeing on the internet, and this is coming from medical journals and from experiences in medical practice. Gallbladder disorders, GLP-1 agonists have been linked to gallstones and inflammation of the gallbladder. Rapid weight loss, a common outcome with these drugs, is also a risk factor for gallstones. Wow. Now, I think, honestly, forgive me if I've pronounced this wrong. Gastroparesis and bowel obstruction, delayed gastric emptying can lead to gastroparesis, and there is an increased risk of bowel obstruction, which is incredibly painful if you've ever had bowel obstruction before. Diabetic retinopathy. Retinopathy? Yes, sorry, I'll get there. I'm not good with medical terms sometimes. Okay, use of semaglutide may potentially increase the risk of worsening diabetic retinopathy, especially in those with pre-existing retinopathy. Acute kidney injury. So I'm not finished yet. Although not fully established, semaglutide has been associated with acute kidney injury. I don't know how to pronounce a lot of these medical names of these medications because I don't prescribe them, and I can't legally, and I don't care to prescribe them. Would I support the prescription of these for a short-term dose for somebody who might be struggling with adherence to a plan, or for whatever reason, I'm not quite sure, or maybe, for example, they're at really high risk of heart disease or stroke, and the doctor says they're going to drop dead if they don't make a change soon, and that we don't have the time if we made dietary changes. I mean, to be completely honest, maybe in some very, very rare circumstances, but temporary is the key word here, temporary. And if they are to be used as a shortcut for weight loss or fat loss, the issue is that in any case with shortcuts, they never work, right? It's like if you want to cheat the system, there's going to be some sort of outcome on the other side that's going to be waiting for you. I would liken it to going to run a marathon, right? And trying to get a head start and driving a couple of kilometers so that you can be ahead of everybody, but you haven't trained for it and you don't have the fitness, and trying to finish the marathon, you lose. It's the same thing. Trying to cheat the system will get you somewhere in the beginning, but not necessarily all the way through, and it will come back to bite you in the ass. Which I think a lot of the time now in today's society, the issue is we have this problem with delayed gratification. People feel uncomfortable if something takes too long to get to them, or if it takes effort for them to have to go there. And unfortunately, because of this short-term gratification that we keep feeding and we keep encouraging and enabling, we then end up with all of these people who are impatient, spoiled, entitled, and believe that they are special and that this is a psychological problem. And of course it is, absolutely. Overeating and overconsumption of food is a psychological issue. Obesity itself is not. It is not a disease of the mind. Obesity is a byproduct of decisions and behavioral changes that have been made, and habitual changes that have been made over time due to lots of different various factors. But obesity is not a disease of the mind. Overconsumption of food, overconsumption of calories, overeating, using food to cope, right? Overeating disorder or binge eating disorder, absolutely. That is, and I would not call it a disease of the mind. I would call it a psychological state, right? Similar to any kind of addiction, drug addiction, that we have somehow got ourselves into a position, and I'll talk about this later in the podcast, where it is now more common than ever. And why did it not exist as commonly or as rife as it is now 50 to 60 years ago? How come we didn't need these medications then to stabilize obesity? Why is it such a problem now? And I do believe that societally it's because of the shift in enabling style behavior, and also the shift away from permanent and meaningful and sustainable change in people's behavior and habits. And the idea that they have the ability to change, and that it is not as complex as they might think. And as I said, the shift away from this long-term gratification versus short-term gratification, which we're now seeing with the attention span of the average human being having reduced from, 30 seconds or so now down to literally a matter of 5 to 9 seconds. So congratulations if you've persisted with this podcast so far. It's just wild. Okay, let's keep going. Tangent. So, medullary thyroid carcinoma is another risk. Studies in animals have shown a potential link between GLP-1 RAs and medullary thyroid carcinoma. Patients with a personal or family history of this cancer are advised against these medications. Serious risks requiring immediate medical attention. Seek immediate medical attention. None of this is on any sort of like pamphlet or website for a nutritionist. By the way, if you engage in my diet and exercise program, you might drop dead. No, that's not a thing. Severe or persistent pain in the upper right abdomen. I don't ever remember having to read that to a client. Severe vomiting and diarrhea. Inability to pass gas or move your bowels. Oh my God. Because why? Because you're not eating enough fucking fiber. Jaundice, yellowing of the skin or eyes, consideration specific situations, surgery and anesthesia. Because GLP-1s delay gastric emptying, there's a risk of accidentally inhaling stomach contents during surgery. Always inform your healthcare provider and anesthesiologist, that you are taking a GLP-1 medication before any procedure. Hypoglycemia, GLP-1 agonists lower blood glucose, which can lead to hypoglycemia, low blood sugar, though this is typically a mild risk. Also a mild risk with dieting if you are going quite low carb, but in general, like just this is just wild. Important note on counterfeit drugs. FDA warns about risk of counterfeit versions of GLP-1 drugs. Oh my God, there is a dark underworld sold online. These products may contain the wrong ingredients. No duh. Harmful substances or incorrect dosages posing significant health risks. Always purchase these medications from state licensed pharmacies. Okay, so let's complete this picture, right? We know that GLP-1 medications, and I say this from a professional standpoint, are a band-aid for a bullet hole for people suffering with obesity. For those who have diabetes, if it's, for example, onset diabetes where a person, it's, developed over time as a result of dietary and choices and lack of exercise, then we know that it's a temporary measure. If they were, for example, born with or as a genetic condition of diabetes, so I believe it's type 1 versus type 2, then obviously some people need the medication because they were born with the condition. They don't, they can't help that they've got it. But there are types of diabetes that can be treated through diet and exercise alone and do not need medication as the, how would I put it, the first point of call. And most of the time, in most situations and scenarios, a general practitioner or a specialist or a psychologist should be recommending dietary and nutritional interventions and exercise interventions as the primary first point of call, rather than a medication for diabetics, especially if it is in relation to diet and exercise lifestyle choices, the diabetes itself, or even as a preventative, right? So it's not like this random thing that just, I don't know why it happens. No, this is why it happens. As I said, if it's not a genetic condition, and I mean genetic as in a person who has been born with diabetes or it has developed over time, not as a result of lack of exercise and smart lifestyle and health choices. Okay, so there's no long-term plan, okay? The big hole in this is there's no long-term plan. There is no long-term plan for the use of GLP-1 medications, right? There's a temporary plan. It's like, okay, let's use this drug, let's lose some weight, we may lose some muscle waste, I don't know, but yay, the number's gone down and I don't have anything for you past that point. Generally is the conversation. You can stay on the medication or you can come off the medication and oh my God, the weight will probably go back on again, unless there has been a significant intervention to your diet, dietary changes, education, and exercise being implemented in conjunction with the use of the medication. Without that, it's completely fucking pointless to take it, because then you are having to go on the medication, come off it when you are experiencing severe side effects and health implications, negative health implications, which can be quite serious. And then you have to go back on it again. And it's this constant cycle. And not just that, in the mix of things, if you are not making dietary changes, you then end up severely malnourished. And the side effects of malnourishment are hideous. Okay, so we see without diet change, nothing changes. Muscle waste over time, mostly due to poor diet choices and not exercising and prioritizing protein. Long-term risks of osteoporosis, iron deficiencies, feeling like absolute fucking shit. Experiencing lethargy due to malnourishment, experiencing dry skin, oily skin, breakouts, hair loss. The list goes on, because as a result of having that reduced appetite, yes, you might be eating less, but you're then eating less of everything, including the good stuff. And unfortunately, that good stuff is stuff that you actually need and that you're not getting. So things like your greens, your fruits, your fiber, things that help you shit, things that help you go to the toilet, the things that literally help your bloating, your fluid retention, all of these foods that you can achieve and consume naturally and source naturally and don't cost a lot of money to get. And you're not eating them because you're so focused on this weight loss medication, but continuing to eat McDonald's and KFC and drink alcohol and not actually understanding that you're still malnourished. And now you're just even further malnourished. Even though you're losing weight, you are malnourished in the sense that your body is not getting what it needs. The essential nutrients, look them up. You would not be getting most of those if you do not make dietary changes away from takeaway, alcohol, living off what we would call, a cardboard diet, basically. Okay, it enables poor behavioural choices with food. The issue with this is when you walk into a GP's office and you get a prescription for this medication and they're not making a proper assessment to your psychological status. They're not having a look at, okay, is this person even remotely thinking about making some lifestyle choices? And they're just writing the script for you. The issue is we are enabling this poor behaviour and these poor choices with food and basically telling people that it's okay to keep doing this and that they're just stuck that way. So we're kind of, in a way, telling people that they're special. they're special, and that, you know, because they only like McDonald's, then it's okay, they can continue to only eat McDonald's because we have a medication for that. It sets a poor example for our kids and our kids' kids and our kids' kids' kids. It just sets us up for absolute failure as time goes on, and we're going to see this in the next 5 to 10 years with the surge in use of weight loss medications. People will still be having things like heart attacks, risks of stroke, high cholesterol, etc., even though they've lost weight, because with saturated fat consumption, it still clogs your arteries even though you're losing weight. If you go over that saturated fat consumption, high cholesterol risk is still there. Weight is not the only defining factor. Wild. And this is the stuff that general practitioners don't necessarily move into with regards to nutrition. General practitioners are general. They're in the middle here, right? They prescribe medications. They do a lot of their studies in medicine. There are other parts of their degree as well. But then they have the ability, they've got these arms which extend out from them, which reach out to specialists, which is the whole referral process. For example, when you need to see someone about, you know, your reproductive system as a female, you go see a gynecologist, an endocrinologist for hormonal function, you see a physiotherapist for physical activity and mobility changes. You go and see, they refer you to a brain surgeon if you need brain surgery, but would you allow your GP to talk to you about performing brain surgery? No, because they're not a brain surgeon. Or nor would you talk to them about issues you're having with your feet. You'd talk to a podiatrist and they would refer you outwards to that professional. The issue is we have too many GPs prescribing GLP-1 medications out like they are candy and not performing the correct assessments, psychological, but both psychological and nutrition and exercise assessments in association with what they should be recommending. But not just that, not just their recommendations. They don't have the qualifications to be able to understand nor prescribe nutrition intervention. Some of them do, but most of them don't. Some GPs are putting people on 1200 calorie diets, ketogenic diets, carnivore diets, and they do not have the scope of practice to be able to do so. They are not legally covered or insured to give this advice with regards to nutrition. So what do they do instead? They prescribe medications because that's the easiest next thing to do that they can choose to do for this client or this patient, right? And this is the danger, is that this is the trigger they can pull. It skips the process of the referral, and not just that, it keeps the client coming back to them for further sessions to pay to see them for another prescription. It becomes the cycle that repeats itself, and it's a very, very lucrative way to continue to earn money. Because guess what? There is no permanent outwards, path from here. A person doesn't graduate going, oh, I know everything about weight loss now. I've been on this weight loss drug for 20 years. They know nothing. They know nothing because the behavior has been enabled. And this is why I get so passionate about it, because as coaches and nutritionists, our major role is to educate, is to help. Our role is to actually help people, to educate them to be able to do this themselves so that we can then move on to the next person and then help them, right? Our role is not to keep the same people coming back and reliant on us, right? Like a crutch. Our role is to fill a person's mind with every single thing that we can for them to be able to continue and sustain this on their own, and for it not to be too hard for them to do, to simplify the process. And this is why I get so frustrated and pent up about this, because the role of a general practitioner is to identify when perhaps nutrition intervention from a nutritionist or dietitian and or a psychologist should come into play. And that may not be happening, unfortunately, with this shortcut of the GLP-1 medications and the assumption that they are going to be the fix. So as mentioned, there's no long-term studies on general population, non-diabetic patients. There are none. There have been general practitioners out there who have admitted, even on shows such as A Current Affair, that we don't have them. It is the first point of call for diabetic patients sometimes, in some cases, but being exercise and nutrition should be the first point of call, right? So unfortunately, we're seeing that people are professionals, GPs specifically, are looking to prescribe medication before giving exercise and nutrition intervention suggestions. They're not even suggesting this. It's wild. Again, not hating on all GPs. There are some wonderful GPs out there that understand that this is malpractice and morally wrong if they did not make special mention to nutrition, dietary and exercise interventions. And the second point of call should be medication. Aside from the fact that it's not being used for its primary use, okay? So initially it is a diabetic medication for diabetics. It's now just being used for literally anyone. It's being handed out like candy. I'm not a big fan of using medications for a secondary use. You would have seen my discussions on using the pill for controlling chronic conditions like PCOS and endometriosis and adenomyosis, being that the initial primary use should be for contraception. And unfortunately, we are seeing that people are using this as a way to suppress their menstrual cycles, and the long-term use of the pill for this specific purpose. Unfortunately, we see the long-term use of the pill and any sort of hormonal birth control for women increasing risk of osteoporosis, reducing absorption of calcium and reducing absorption of iron. So you have all these iron deficient and women going through menopause, having been on the pill or some sort of hormonal birth control, and also wondering why they've all of a sudden got osteoporosis, early onset osteoporosis. Psychological impacts long-term can lead to addiction and trouble coming off the drug when they need to. So they have an attachment to this drug because there has been nothing put in place instead for them. No plan, okay? No outward plan. No sort of like, hey, by the way, this is where we're going to head. And for me, when I look at what I do with clients, I always map out, this is what it will look like in the future, you graduating from this, like how can we get you to a point where you can do this on your own? And I celebrate when a client can. So behavioural and lifestyle intervention is key, okay? And education. It's not that fucking hard. It's not that hard. And if people want to turn around saying things like, I've tried everything, they have not tried everything. They've tried diets. They've Googled diets. They've not worked with health professionals, and if they have, they might have worked with a dietitian, had a couple of sessions and given up. They've not worked with someone long term. They've not worked with someone like a psychologist who specializes in disordered eating behaviors, nor a nutritionist who can work on things like their environment and behavioral interventions long term, because this shit takes time. Patience and time, which a lot of people are unfortunately not practicing. Working with a quality coach is worth their weight in gold. And guess what happens? Okay, you end up investing money from the drugs that you would be spending for a lifetime on and off into a coach and a psychologist for a short period of time. And I would consider that to be 1 to 3 years. Okay, maybe even less, 1 to 2, maybe even 6 months to a year. Long-term education means you will no longer need a coach one day, which means you will no longer need to spend the money on a coach. Whereas with the medication, you will need to continue to spend the money on the medication if you do not learn anything about your nutrition and your exercise whilst doing so. Nor do you implement the changes, okay? You come off the drug, the weight goes back on because everything remains the same. Okay. Medication reliance means a lifetime of use until you solve the issue at hand, okay? And willingness to change and self-awareness, just like any addiction or behavior, is a part of this process as well. You need to be willing and wanting to change. If you are not, then unfortunately the use of the medications, the side effects, and the constant self-enabling and others enabling your behavior or the behavior of others is going to be a part of this cycle. Change is not as scary as you think, okay? Change is not as scary as you think. If you are worried or scared, have a chat with a specialist, a practitioner, a nutritionist, a dietitian, someone like myself, because trust me when I say the easy way out is easy, but there's just no longevity. It's easy for now, but what does it look like in the future? Have you thought about that? Have you thought about the next 5 years, the next 3 years? This is something we don't have enough information on, and I'm actually excited but also very afraid to see the results of what happens long-term to these patients, to people who are on these medications long-term. Anyway, that's it from me. Going to finish up. The sun is setting. I'm probably getting very dark. I hope you have a wonderful evening, morning, wherever you are listening to this podcast. Looking forward to doing another one for you soon. Bye-bye.